Good day and welcome to A Look Back, the 2012 AIDS Conference. Our guests are Dezan Dixon Diallo, founder and president of Sister Love, Ambassador Eric Gooseby, U.S. Global AIDS Coordinator, Jennifer Cates, Vice President and Director, Global Health and HIV Policy, Kaiser Family Foundation, and Phil Wilson, founder and president of the Black AIDS Institute. Now, here is our moderator, journalist George Curry, editor-in-chief of the news service at the National Newspaper Publishers Association.
Welcome to our webcast. Well, the 19th International AIDS Conference has ended, and today we take a look back at the highlights of the week. I'm happy to welcome all of our guests. Let's start with you, Ambassador. We haven't had a conference here in 22 years, so why is this important and what significance do you think this will have?
Well, I think you're right. It has been 22 years. The last one was in San Francisco. The addition of adding HIV as a criteria to deny a visa was the reason that the conference has not been back in the United States. Both President Bush and President Obama have really worked hard on trying to change that. It wasn't until President Obama's administration came in that we were actually able to get it changed. But now that no longer exists, people were opened up into the United States for this meeting, and the IAS decided to potentiate that decision by deciding to have it here.
What impact do you think it'll have?
I think it has a tremendous impact. When we talked last week, looking ahead at the conference, we were saying how important this could be to have the conference here and really connect the global and the domestic and allow people from all over the world to really come together where a lot of the leading research and really the first cases were discovered. And I think that actually happened. I mean, there was such a connection made continually between the epidemic all over the world, the epidemic in the U.S., so it was pretty significant.
Phil, you've been to a lot of these, and we usually not here. In fact, all of them, as a matter of fact. How do you think it's going to help, just simply having it in Washington, D.C.?
Well, it's been a wonderful week. The theme of this conference is turning the tide together, and it's an opportunity to bring the world stage to the United States, and that has been good for a whole host of reasons. But the top two reasons is that it provided an opportunity for the world to see our epidemic. And as a Black American, it's critically important to me and others for the world to see the epidemic in Black America. But it also allowed for the United States to have exposure to the rest of the world. This is a two-way street, that we have an opportunity that we can certainly teach, but we have an opportunity that we can learn, and that happened a lot this week. Everywhere you went, folks were talking about how does this translate, how does this other thing translate. We do a breakfast updates now, and there were people from all over the world in our African American breakfast updates every morning. That started at 7 a.m., by the way.
Dezan, what about outside of Washington? You think they're paying attention?
Well, absolutely. I think they're there. That is, first of all, the conference isn't over, fortunately for some of us at the local level, because there'll be opportunities for communities to continue to broadcast different and very important messages that came out of the conference in local conference hubs. So there are going to be other opportunities for us to have these conversations more locally across the country. So I absolutely think so. I also think that what we look back on is one of the things that we set out from the women's community was to also do two things, which was one, to close that bridge or that divide between what's happening with half of the epidemic in the rest of the world, because women are more than half of the epidemic globally, with women in Africa and other parts and women in the U.S., and that we had more voice and more representation of women at this conference than I think we've ever had before in every aspect. And so I think that is going to resonate locally as well.
Ambassador, you got a new assignment, I understand, from the Secretary of State announced that you'll be coming up with a goal, a plan, a blueprint. Tell us a little about what you'll be looking at.
Yes, well, Secretary Clinton, in her speech on Monday, challenged the creation of a blueprint that really maps out where and how we get to the AIDS-free generation. It's the type of thing that I think will allow us to focus our discussion and the needs that different groups, different stakeholders in this feel are critical. So there'll be a process that allows for that type of feedback and participation. But it'll also give timelines, objectives, outcomes that we are trying to see as we move toward implementation along the way. So there'll be some process outcomes as well as some final outcomes.
The U.S. has been a global leader here. How do you get countries to step up saying, okay, you can have a larger responsibility here?
Well, the United States has been the global leader and will continue to be. I think one of the affirmations that came out of this conference was the clear message from the highest levels in the U.S. government that this indeed is a priority, will remain a priority, and we are going to play our part to achieve that AIDS-free generation both globally and in the United States. I also think that the United States has taken the lead in the research along the way, 30 years along the way, in really every area of substantive research, from natural history to prevention interventions to antiretroviral treatments to the diagnosis and treatment of opportunistic infections in the United States and abroad, as well as the development of what is now more hopeful, the development of a vaccine. Tony Fauci put on the table the continued interest and now growing interest in actually still working and putting resources toward a cure. All of that activity has really culminated, I think, in a statement that the United States has played a part, will continue to play a part, central part in moving towards an AIDS-free generation. But you're absolutely right to challenge us around how countries step up. Countries have been fighting this epidemic for 30 years, so it's not like they've been standing in the background looking at it. But their ability to mount the strength of a response for the numbers that we're talking about in many of the sub-Saharan African countries in particular has really required that we acknowledge that they're going to need help and that there's a shared responsibility that involves the ethics of it, that other countries truly need to step up to the plate to support our implementing countries in their responses. This is an attitude that we have been talking about for 2 years. We are now seeing significant movement in sub-Saharan African countries to allocating resources out of their budgets toward the HIV response in their country. So the countries are beginning to invest in their people. I'm optimistic that over the next 3 years we'll see much more.
Okay. Have we connected the global with the local, the U.S.? I mean, people look at the globe as, we can kind of almost like separate our struggle against the global struggle. Would you put that in some kind of context?
Go ahead.
Well, I think that what's interesting about this conversation now, that for people who are living with HIV, we've always been connected globally. We understand that whether I live in Los Angeles or whether I live in Lagos, whether I live in Abuja or whether I live in San Antonio, that there is a relationship in our experience and that we've been building a global network of people living with HIV since the very, very beginning of the epidemic. I think that one of the things that happened at this conference is that we went to the next step on an institutional level and a structural level in marrying the two. I think that prior to this conference, the conversations around the epidemic fell into this paradigm. There was the domestic epidemic, and then there was the global epidemic. And I was at a recent meeting, and I said, I don't know how you get there, because when my kids were in school, to help them learn geography, we had a globe. And honest to God, when you spun that globe, the United States was on it. So how can you have a global conversation where the United States isn't a part of that conversation? And I think we got that, and we got that here, and nowhere was it more evident than in the global village.
Okay.
No, I completely agree. I actually remember 2 years ago after the last conference, and we all had an idea it was coming back here, and we said, we really need to connect these two. And it started at that. The process of planning to get here actually began connecting those two things. And I mean, just having so many moments where Ambassador Gooseby and Grant Colfax were together, showing the sort of two governmental leaders on global and domestic. And if you even look across the different emphases and plans, combination prevention, highly effective prevention impacts. So there's a lot of convergence. And it's not just U.S. and global, it's local and global wherever you are. And I think that's what this conference is really about, and definitely epitomizes what the global village is showing.
Ambassador, you said an AIDS-free generation isn't only something we can achieve, but we must achieve. What do you mean by that?
I mean that the science that tells us how to both stop progression of disease in an individual and to stop progression of HIV through a population are now known. We now know that some are better at achieving those goals than others, that there are specific strategies that really should be done because they have that high impact that Jen is talking about, and that we need to have the courage and the determination to make the decisions to shift to high impact interventions. When we do that, we will drop the number of new infections. Our modeling of the relative contribution of different behavioral as well as biomedical interventions, matched with now the fact that treatment does drop your infectivity so dramatically, really does change our metric on when we'll achieve a drop in number of new infections that actually is less than the number of individuals that are going on antiretroviral therapy. We're about to cross those lines in so many countries in sub-Saharan Africa that our predictions show that over the next 2 to 3 years, we really will drop precipitously down. So we indeed are putting more people on treatment than are newly infected, at which point the inflection downward will be accentuated.
What can we expect from PEPFAR in the future?
PEPFAR has increased its focus on high-impact interventions for prevention. We've aggressively pushed our programmatic portfolio in every country to favor those funding of the high-impact prevention interventions. And we have scaled our treatment where possible, where it can be done relatively quickly and effectively to in the general population. But I think the third piece that we've done is we have aggressively now focused on targeting high-risk populations. So we get our behavioral interventions as well as our testing to identify positives to initiate treatment in these populations more aggressively. The world has lagged behind in this response. PEPFAR has as well. We see it, and now we're shifting to address it.
Okay, I'm going to ask you another question because I'm going to have them later, so I got to take advantage of the time I have here. Sure. You've been involved in a lot of programs where you've been scaling up, I think, Rwanda, South Africa. Tell me, how do we do that, and why that's so significant? How can we really scale this up?
Well, I think everybody at this table has been in different aspects of understanding the best way to scale up. The first is to understand your epidemic. You need to absolutely be able to say, this is who is seroconverting, becoming HIV positive in our community. You need to understand that an epidemic in one country, understanding it kind of at the 30,000 foot level, there are actually hundreds of epidemics that are occurring, not just in each country, but in each city. And if you don't have your medical delivery response acknowledge those differences, you don't get in front of the virus moving through populations. So mapping your epidemic, understanding the epi, understanding the demographics, and then going backward from the population to make sure that there are access points for all the services that you want to put in play. That is not an easy thing to do. It's an easy thing to say. And our struggle has been in understanding the realities that populations have and comfort levels that are present or not present in revealing themselves to medical delivery systems. We cannot expect individuals who are participating in the highest risk behavior often, but are also participating in activity that the country pronounces as illegal, to feel vulnerable in revealing themselves to a medical site for fear of being arrested, incarcerated, or discriminated against. We have got to aggressively acknowledge that this is a major barrier in accessing and being retained in care, and requires a multiplicity of different interventions, including a strong diplomatic dialogue with the political leadership in country to get some of these things better understood, but more importantly, changed.
You just touched on an important thing there, because there is certain parts of the world where people just have totally backwards attitude about this. How do you say engage them diplomatically? How do you change that? That sounds like a major barrier.
It is a major barrier, and I really am sitting at a table with people who have put much of their professional work toward trying to identify mechanisms to minimize those barriers. But the main issue is that I have found is most successful in the dialogue in countries that are hesitant or actually hostile toward these populations is the discussion about how the virus moves through the population, explaining to leadership that if you ignore these populations, you will continue to fester with your epidemic. And the festering, because you have driven a lot of the behavior down underground, people not wanting to reveal their lifestyle change choices to their family and community, do it secretly, and that much more increases behavior that is unchecked and uninformed by information that would decrease sexual risks of transmission, especially injection drug use, in needle exchange, etc. All of those types of strategies to minimize the transmission are not, the individuals don't benefit from it because they're trying to shun any involvement. Governments do understand that the population at highest risks will move virus into the general population more aggressively. Pediatric epidemic is a perfect example of that. If we do not apply a aggressive strategy to create access points and strategies for retention.
So you're saying, basically you make an argument of saying, look, you may still have these views against these groups, but if you ignore them, everybody's going to be impacted.
That's right. And you know, the medical profession is not in the business of having to judge anything. And they should not get confused about judging something and making a correct public health, medically generated scientific decision to respond. And that's the arena of the discourse.
Well, I would say that that's the medical version. I think that from a policy standpoint, we have to hold the same accountability. I give you the example, we heard and talked a lot about criminalization of HIV and how it exists not only domestically but in many places around the world. And the key example for the women's conversation is the prostitution pledge and the restrictions that are set aside inside PEPFAR. It's really odd that we are spending millions and millions of dollars of making sure we get condoms in the hands of people and then arresting people because they have condoms in their hands. And so we're working at this counterintuitive place if we're not looking at all of these issues throughout. And I think that if we don't do something to change some of those critical issues on the ground in these countries, but also even as it's attached to the funding that we offer, then we're still going to be looking at these challenges way down the road.
And on that point, you know, I think it's really important for people to understand when Dazan talks about people being arrested because they have condoms in their hands, that we're investing millions of dollars to make sure they have condoms in their hand. The country they're talking about is this country.
Thank you.
Okay, right. I'm not sure because we're having this global conversation.
Yes,
you
but
know,
it's applied to that
in
global
fact, if you
support.
have 3 condoms in primarily, overwhelmingly women, now if they have 3 condoms in their possession, that is used in some states as evidence now that you are a prostitute. Now, and that is absolutely outrageous.
We'll come back to that in the next segment.
Okay.
But on
I
this
mean,
last
it's
one,
Thailand,
I
it's
want
other places, yeah.
an ambassador to ask this. What are your lasting impression of this conference before we go to a break?
Well, I think that it's been said that this did really narrow the divide, if I could use that such a strong term, between the domestic discussion dialogue and the global dialogue. I really too felt a convergence of the two efforts. And I feel that the other big kind of message out of the meeting was a rekindling, a rejuvenation of energy, and I was not expecting that to happen. I'm old and cynical enough about this stuff that I say, you know, unlikely, but I have to say I felt a lightening of spirit in the meeting that I was surprised at, and I'm very grateful that occurred.
Well, certainly want to thank you for an interesting discussion. We'll continue with the other 3 while you're leaving, but we'll have to have you back. How about 2 years from now? We have next time before that even. When we return in a moment, we'll talk about the conference and the U.S. epidemic. Welcome back. Joining me again are Phil Wilson, Dazon Dixon Diallo, and Jennifer Cates. Phil, let's follow up on something we started in the last segment. You're talking about the condoms and how if women have a certain amount with them, they can have problems with the law.
Exactly that. One of the barriers that we're going to have towards getting to an AIDS-free generation is irrational criminalization of HIV. One example is using the possession of 3 condoms as justification for prosecuting a woman for prostitution. Another example is these disclosure laws where people are being prosecuted. There's a case in the Midwest where someone has been sentenced for an extensive period of time for non-disclosure. Even in a case where there was no transmission, the person had undetectable viral load. We know that with undetectable viral load, this person had a 96% chance of not transmitting the virus. Plus, they used a condom. And so when
you said non-disclosure, what are you talking about?
Well, it means that in some states, if you don't disclose your HIV status, you can be arrested for that. Primarily, I think the goal is around sexual contact, but in many states, it's not clear how a prosecutor, an overzealous prosecutor, might use that. So, but the reason why it's a problem is that when we are trying to urge people to get tested for HIV, and we already have an example of mass incarceration. We imprison more of our citizens than anybody else, then that creates a barrier. People are not going to get tested for HIV if they think that it increases their probability of being.
People are not getting tested.
That's right. People are already not getting tested.
I have women tell me all the time after we do our community education, I say, well, why would I want to get tested? Because not knowing your status is the only defense you would have in a situation like that. And I think what's also important, though, about that is that this was a global meeting where a lot of these things came out because it's also immediately tied to the connections that we've been able to make. So it's not just here that our policies are impacting people's ability
before I go
to
to
protect
Jan, what do you say
themselves.
to? But what do you say to you, woman? Say, hey, I don't want to know.
So what do we say to women is that you really, 2 things, that we have to get to the point of disclosure. And for me, it's about when you get tested, knowing your status is important. Being able to share your status is even more important. Whether it's a negative result or a positive result, the supports that you need to be able to have that conversation with any partner becomes important because that becomes your defense. In any situation, is say, well, they knew. I said what I needed to say, and we all took the different steps and actions. I know, and just to give the example, there's a case in, I think it was in South Carolina, where through a nasty divorce and a conflict over the children in custody, where the woman had disclosed to her husband, but because it was a, he said, she said, the court, and I think this role of stigma comes in here, believed him when he said, I never knew. And she ends up not only losing out in the divorce, but also losing her children.
Okay.
Yeah, I would just say that, I mean, the bottom line here is that we need an environment where people can disclose, and that's okay. There's no criminal penalty for disclosing or not. There's no stigma, and that's what we're trying to work towards. So these kind of situations are not dictated by public health. In fact, public health would say that this is contrary to public health measures. And one of the challenges we face in the U.S. Around achieving an AIDS-free generation is a lot of this is state level. It's what states do. Gotcha. And so, we have 50 states in D.C., and they all have different laws. And so it's not just a matter of a national consensus at a federal level coming up with what's the right public health measure. It's really a state-by-state process. But the bottom line is when someone should be able to disclose when they feel comfortable to disclose, and they shouldn't face any negative result from that.
And the overall thing is that our policy should be based on sound public health science.
Right.
And when we base our public policy on other things, we do harm to all of us.
Okay, Phil, you treated like a rock star this week. I mean, you gave this great speech. I've never seen this kind of reaction, and 2 African American and women were so involved in this conference.
No, absolutely. I think that the speech that I was privileged enough to deliver on Monday, first of all, it was a result of a whole community effort. We did 25 hours of consultation. We got online input. So it was a community effort, and that was our goal. And it also symbolize what we were trying to do in this entire conference. Now, this needed to be the people's conference. It particularly needed to be a conference, now from my perspective, and I'll grant it as a limited perspective, I wanted to make sure that the voices of black people were heard and seen in this conference, that we were present and that we were engaged and we were active, and that's what the opening plenary was about, and I'm really happy about that.
You did a great job. Let me take a quote from your speech, and because I want to talk about the U.S. epidemic. You said this that just jumped out at me. You said almost 6 in every 10 black gay men in America will be HIV positive by their 40th birthday. That's an astounding stat.
It is, and to put it in context, now that is a combination of prevalence and incidence that makes that happen, but it is a HIV environment that rivals, the epidemic that you're going to see anywhere in the developing world, and an epidemic that's worse than anything that you see anywhere else in the developed world.
That's amazing, and I saw another stat. They were talking about gay men, but black women, among women, 57% of African American women, and then with teenagers, 15% of the population, 70%
Yes.
of diagnosis.
Yes, absolutely. And that's the national.
Exactly.
When you start to look at the concentrated epidemic in regions or in certain urban communities, it even rises. In the South, black women, for example, are anywhere from 75 to 85% of the epidemic among women. And we're not just a quarter of the national epidemic, we are actually 30% and more of the epidemics locally in our regions. And so I think that this also points to some of what Phil was talking about, and we also wanted to make sure, and I think that happened at this conference, that we actually heard from more women and about the science of women's reproductive health and HIV, because that's the critical juncture for us. And the other thing that was, I think the Positive Women's Network had a fabulous press conference releasing the latest data on the role that trauma and violence play over the lifetime of women that increases their risks and vulnerabilities to HIV, whether they're negative or whether they're positive.
I think I saw some stats talking about how the South is disproportionately affected. Of the 10 worst states with the problem, 8 of them in the South?
Yeah, the
Yes.
South is disproportionately affected. Well, the South historically, and not just in HIV, has higher rates of unemployment, of poverty, of STD rates are higher. I mean, it's a whole confluence of factors, lack of resources, relatively speaking, and you put that together and you really create a situation where HIV is going to be more of a challenge to combat. And I think there are a lot of data that show that. There was one study that came out that looked at resources matched recently, it was just this week, looking at our resources really tracking, and found that they're still not quite tracking with the epidemic, although CDC and others have put in new ways to distribute resources and really target that's supposed to address that. But it's a combination of factors that really create a challenge, and for women in the South in particular.
And that's overlay also in the epidemic, and there's a press conference on Wednesday that Greg Millett participated in, where they identified that 2 of the 3 worst cities for black gay men in regards to HIV were also in the South. So we see it whether we're talking about women or whether we're talking about gay men or whether we're talking about other populations. And I do think it's a matter of resources in part.
Yes, it is. Resources and the fact that we have an extremely more entrenched level, I think, of stigma and of discrimination. That's a confluence of race and class, and the resources and gender and the resources themselves.
Throughout the conference, I kept hearing too, there's not enough connection up with the treatment once you do make this diagnosis.
And I think that's a really big issue. I think we're all excited about treatment as prevention. We're all excited about treatment for treatment. Study after study, there was new research released just last night that said, well, we know this from other studies, but it was really a very definitive finding that treatment, when you take treatment early, antiretroviral treatment early, it has tremendous clinical benefits for individuals, and we know it has tremendous prevention benefits. So that's great, but we're not going to fix our treatment cascade problem, which again is, are you getting diagnosed? Are you getting linked to care? Are you staying in care and getting antiretrovirals and then virally suppressed? We're not going to fix that unless we get at some of these more challenging issues. There was data that released this week saying, let's look at antiretroviral use and viral suppression among black gay men compared to white gay men, and lo and behold, black gay men had less access to antiretrovirals in care. They were less likely to be on antiretrovirals and less likely to be viral suppressed, even though they were in care. that if we don't, that doesn't get addressed, we're not going to get to the AIDS-free generation that I think we all know we can get to.
So, but how do you take that from this conference out to the communities?
Well, you know, today there was a late breaker that talked about what we've been calling the Gardner Cascade, which is basically the process from being diagnosed with HIV to viral suppression. And so one of the things we need to do is have the tools that we need. One of the problems that I complain about is that there's so many things that we don't know that we could know. And so, for example, we know what it looks like from a national level, but we've not known what it looks like diagnosis to suppression based on race or based on gender or based on geography. And one of the things that we need to do is to have that information. And at this conference, we got that information. Now we have that information divided. But the second thing we need to know to answer your question is we need to build an army of folks who are trained and understand the science but are rooted in the community. Now, and we need to marry the community to the science.
How do you do that?
Well, I think that you do it in number one. You train folks. You know, our AIDS service organizations now need to be retooled. We need to integrate the behavior with the science. I think there's been a fear that as we medicalize HIV, that the behavioral work will be less important. But there's going to always, always, always be a need and the demand for the behavioral work. Because you know what? As great as these pills are, I have a pill box on my nightstand. Those pills do not have a way onto themselves to get into my body. Now, them getting into my body requires me to do something. And guess what? That requires behavior.
That's right. Yeah, I've always said that everything about HIV begins and ends with behavior, and anything else falls in between. It's a 360-degree. I think the other thing that we can do to take this message home is, first of all, like we said before, there are opportunities for folks to continue this conference conversation. They can go online to AIDS2012.org and they can register and host their own conference hubs and bring down the science, especially after we've got late breakers coming out today for that. But I think it's also important that when we're talking about health literacy and research literacy and bridging those two, because it also is connected to the changes that are happening in terms of the Affordable Care Act. People are going to need to know communities are going to need to know how to navigate differently and what these things mean. But it's also immediately connected to what community-based organizations have been responsible for and what they're going to be responsible for going forward. They're still going to be the front line to translate all of this, and if they can't speak the language, then things will get lost in translation.
That's right. And Dezan mentioned the Affordable Care Act. What people living with HIV and people who care about people with HIV have to know that the Affordable Care Act is the most important thing that we need to do to get to an AIDS-free generation in this country, and it is in danger.
Yes.
And unless we fully implement the Affordable Care Act, there's no way that we're going to get to an AIDS-free generation.
And they have to understand that it is both for HIV positive and HIV negative people, because there's so many additional preventive services, including HIV testing and counseling and STD screening, and for women in particular, violence prevention is now covered in health care. So it's not just for people with HIV, but we all have to understand protecting the Affordable Care Act is going to help us also get to the AIDS-free generation.
I think we all agree on this. I mean, the Affordable Care Act is going to expand access for millions of Americans, including many people with HIV and many people at risk for HIV. And that's going to change. I mean, that is what's going to help affect the cascade problem that we're all talking about. As of 2014, people with HIV can't be discriminated against in the insurance market, which they still can, or by law that will no longer be the case, which is a huge change in reducing stigma too, not just giving people access. There'll be opportunities for states to expand access to cover many, many more people with HIV under their Medicaid programs. People will have more insurance access, but again, we're going to have a state-by-state challenge here, and it's really going to be going across the country and trying to figure that. And I want to connect that to what Phil was talking about with the data coming out today, and being able to say, if we look by geography, if we look by race or ethnicity, where are the biggest challenges in this cascade? Why that's so critical? Because if you can connect the dots between the science and the community trying to make the biggest impact, if you know that your biggest challenge in your community is the challenge between getting someone to know their status, that's what you focus on. If you know your biggest challenge is someone had one care visit and then we lose them, you focus there. If you know that they get antiretrovirals but they can't keep on their regimen, you focus there. And that's the information we need. Because if we don't have that, we're not going to be able to go forward.
And so this whole thing, so we got to get back. You're saying despite all the great advances we have in science, you still got to get people tested.
Absolutely.
And you got to get them involved and say, okay, once you get tested, you got to be able to provide the treatment there. And right now, there are too many holes in the system.
Right. And quite frankly, they got to vote. You got to get tested. You got to know your status. You got to get into care. But you also need to know that your participation in the political process will determine your ability to have access to those things.
I was moderating a panel yesterday because Phil asked me in the last minute, but he had to go to the White House, of course. Right. And there was a guy saying, you know, there's still some cultural things out there saying, guys, I don't want to know. Right. How do you get past that? To saying, what do you say to somebody saying, you don't want to know?
Well, I think that there are a few things we need to do, and part of it is some of the structure. One of the reasons why people don't want to know because they don't know there's something that they can do about it. Okay. So we need to help people understand there's something that they can do about it. The other thing that I think is helpful is that there are some of us who know and that we can come out. Now, the more of us who know and who come out about our HIV status, the easier it is for people who don't know to want to know. And it's the easier it is for folks who are afraid to come out about their HIV status to come out. And the reason why that is important for two things. People living with HIV are the best case to fight stigma. Secondly, we need to drive demand for the treatment. People are not going to build the kind of infrastructure we need on speculation, because we theoretically think we need it. The more of us come out, the more of us that can demand the kind of treatment that we need.
But aren't you asking a lot to feel when you talk about the stigma? When you ask a person, saying, look, I want you to come out so you can be stigmatized. I mean, how do you deal with that? I see your point, and it's important for them to come out, but then they say I come out and I get treated. I get stigmatized.
Well, first of all, I want people to come out so they can stop being stigmatized, because they're being stigmatized already. Right. Okay, let's be clear. Whether you come out or not, you're being stigmatized, and sometimes you're stigmatizing yourself. You know? And so that part of the message is that if you come out, the more of us come out, not necessarily, I realize there are limitations for some folks, but there are some of us who can come out, and we can start with us.
Okay, you're talking about how somebody else looks at you, but I'm saying for a lot of people, when you talk about the problem of society, how do we get people who are not HIV infected, who say, okay, we need your support on this. We need support of people who are not, that people won't look at them and just cast about.
You know, I think we need that, and we should, and we've shown that you can. I mean, when you so many people in this country actually know someone with HIV, or know someone who's died from HIV-related complications. So, first of all, it's tapping into that and saying, this is, we really all know this and feel this. But I also think once someone starts to get involved, when someone starts to interact with helping people with HIV, working at the service level, working at the policy level, they can't stop, because it's one of the most compelling things you can be involved in to capture a lot of challenges that our society faces and how you can really make a difference. You know, it's in Congress, members of Congress often go to Africa, and they'll go to different countries in Africa, and it really changes their mindset. We need to do that in the United States.
And George, we already have an example in black communities, and you know this now, because we still have issues in black communities, but black community has moved dramatically now over the last 10 years. Yes, you know your colleagues who are journalists, you know, they've moved dramatically. And part of that is because 60% of black folks know someone who is living with HIV or died from HIV. You know, and when that happens, it changes your attitude, it changes your perspective around HIV. And
from a very personal and individual level, because we work so closely with women around disclosure, which I think is even more unique, because we're responsible for so much more. And our youth, our children, our own children then become a part of that process, and then there's school systems, and so there's so much more that your disclosure engages. But what I have seen, that transformation, and we've seen that evolution sometimes, where I can talk to a positive woman and say, I know you're about 40%, aren't you? There are certain spaces where she has learned that it's safer. Well, usually they're in communities where they're totally isolated, and then they find out that there are other women who speak, and then they get support, and they have energy, and they get recognized, and there are benefits to that, right? Some of them are now traveling and sharing their stories and meeting up with other people that are now like them, and where they didn't have that before they disclosed. So I think that there's this development factor that enriches your own sense of self-worth after disclosure, because that disclosure opens up a world of support that you didn't have before.
Clearly, we know the black community has been impacted more than the other community. But what about outside of the black community? What kinds of things that came out in this conference that stood out in your mind?
Well, one of the things that I'm really, really excited about is the Black-Latino partnership that happened at this conference.
Yes.
You know, and I want to, for the
Tell me
camera.
outside the black community. He said, "Okay, fine, I'll do it with the Latinos."
Well, you know, there is an important
Go ahead,
statement that I think for the history that. No, and it's important for me to say it because I'm so focused that the black community was recognized at this conference. It would not have happened without the support of the Latino community. Absolutely would not. And so I'm thrilled that even though we highlighted the black community, that we were able to be inclusive of all of our communities at this conference, and that was really important.
What else in terms of the science that stood out for you?
I think it was affirmation of what the scientific findings in the last couple of years that we were starting to see. It really solidified the science in many areas. I think there's excitement now about rejuvenating the conversation around a cure, whether that's a functional cure or a cure. So that's there. The treatment as prevention, hitting that home. I'd say those were the highlights for me. And there's so many studies that came out at this conference that I'm going to spend the next month probably trying to assess them all. But I think what the main message for me was the science is clear. It's about implementing the science. Okay. So that's the main take home, I think, from this conference.
The treatment as prevention was really, really a hot topic.
That one, but there were so many, but that's it. It's the science is there. In the past, we've been in a place where we still needed more science in some key areas because we weren't quite sure what we thought we knew, but we needed to have more. I think we have it. So now it's just doing it.
I think that also, though, out of the science, it also helped us see what we still don't know. Yeah. And I think that that's really important, especially when treatment as prevention is a lot more clear than pre-exposure prophylaxis. Right. And while there was a lot of high energy, and this is what I think I saw happen this week, which I was pleased about, is that while there's a lot of high energy around the opportunities and the possibilities of pre-exposure prophylaxis, which is very similar to treatment as prevention, except we're talking about people who are not living with HIV, that they're HIV negative, is that we still don't know a lot more about the longevity for people who are not HIV positive. That means we still don't have some sort of biomedical or non-condom option for people living with HIV. If it's with pre-exposure prophylaxis will not be good because it won't help if you're on antiretrovirals and then you're exposed to other antiretrovirals that may actually increase your resistance to the virus as opposed to helping prevent the transmission. So I think it was also important for us to frame the research agenda going forward out of all of the new science that we know.
But there is one point of clarification that I think about PrEP. I think that what we do know is that PrEP does work for men who have sex with men.
Yes,
that question has been answered.
Absolutely.
Now, we have to do more work about women. Now, certainly we have to do some work about durability. I mean, it just recently got FDA approved, so we'll see what happens in durability. But there's some prophylaxis that at this conference we saw is durable. Now, voluntary adult male circumcision, we found that is durable, and that was very, very important.
Yes. The other thing I think that is important to clarify with all the science and what we do know and don't know is that these are all different types of interventions, and some are the kinds that you really are much more, you would scale it up to an entire group or entire population, and others are much more targeted. So treatment for treatment's sake, treatment for prevention, scale it up. I mean, the science is clear. This is going to help everybody. PrEP, much more targeted right now. Yes. Voluntary male circumcision for populations that haven't been circumcised and are at risk. So I mean, it's not just that everything's up for grabs and just go. It's really about deploying it where it makes the most sense and at the right scale.
There was a lot of talk about an AIDS-free generation and the end of AIDS. One is, let's define what that is, because and secondly, is there a danger there of seeing people getting too comfortable with that expression?
Well, I think Jen should answer the first question, and I'll take a stab at the second part of it, and that's whether there's a danger or not.
I think there's a couple answers to the first one. I mean, it's clear that we can AIDS as sort of the very advanced stages of people being sick. I think we have all the tools to say that does not need to be the case. But I think we're looking beyond that to say we want to get to a place where we've bent the curve and we've gotten to a point where people are not being born with HIV, people are not being infected with HIV. That's really the goal. We're not there yet, but I think we're much closer to being able to realize it in the not far away future than we had hoped we had been before.
And that's how we define success.
It is how we define. I mean, ultimately, that's how we define, and that people who have HIV are able to live, as healthy and long a lifespan as possible, and that will also contribute to an AIDS-free generation in the future.
I mean, basically, materializing the vision of the president's national HIV/AIDS strategy, that the United States will become a place where HIV infections will become rare, and when it does happen, that people have unfettered access to care, regardless of race, gender, sexual orientation, socioeconomic class, or region of the country where they live. But to your question, is it dangerous for us to talk about that we can end the AIDS epidemic? It's dangerous if that sentence ends in a period, but it doesn't. It's a semicolon, okay? We can end the AIDS epidemic, semicolon, if, and it's a big if we act now and if we do the things that lead us to ending the AIDS epidemic. But if it's a period, it is dangerous. But if it's a semicolon, what it does is does two things. One, it gives us hope, and it reminds us of the work that's left to be done.
And the other thing that I noticed about the conference that I thought was we had at the beginning of the meeting, there was all of this excitement around the PrEP and all of that. And the AIDS-free generation, I think your talk and Secretary Clinton's talk really hyped everyone up to that level. And then as I got to more presentations and more of the science, it just kept coming forward that we can get there. And there's so much work to do. So by the end, like by today, we've sort of tempered out that excitement literally to, okay, now we've got to get back to the grind. And I think that that's a good thing.
Yeah. And two other thoughts on that. I mean, where there's a risk or a danger is saying that if we're all agreeing we can get to an AIDS-free generation, semicolon, we have to do these things. That doesn't mean that the attention, the resources, the focus can stop now or ease up. It kind of means the opposite. So it's making sure that message comes through. And then HIV is an epidemic. It's an infectious disease. So what we've known from past infectious diseases, you have to really make sure you've put everything in place, because if you turn away, you could be at a problem. That's happened with TB. It's happened with malaria. And so it's really a vigilance that has to. It may change. We'll get to where we need to be, but we have to be very cognizant along the way.
Yeah, it is dangerous to say mission accomplished prematurely.
Right.
Yeah, we know.
We know that before. without getting political. I want you to look back. And we talked about, because all of you were here, we talked about what we expected in this conference. Now, looking back, with the benefit of hindsight, did we accomplish what you thought this would accomplish, this conference?
Well, I think we're going to find that out over the coming months, to be completely honest.
You got to answer me now.
I think and I'll own my entry into this. I think that this conference was a huge success on every front. I think that we talked about what we need to do. We talked about how we need to do it. We talked about who we need to do it for, and all the folks were in the room at the same time. And I think that's the measure of a successful international AIDS conference.
I completely agree. I think it was a success for those reasons in a huge way. And I also, for all of us who have been working on both the domestic epidemic and the global epidemic for a very, very long time. And I really wanted to experience them being connected, and I was hoping that would be a strong feeling. It came through much more than I even expected. To me, that's a success.
What did you expect?
I just didn't, I guess I didn't expect that many speakers, whether it was our U.S. government officials who focus on the global or the domestic, or people from other countries coming, I didn't expect the connection to be made by so many people. And I really think if that connection is what's going to help us move forward. It's not just about the U.S. I just mean seeing the connection is really what we have to own to really move forward.
And I think the other connection that happened this week more strongly than I've seen before is there actually was a closer relationship or connection between community and science.
Definitely.
And I think that was it. I know that it was very intentional on behalf of Black AIDS Institute and Sister Love and so many organizations to make sure that we're putting both groups at the same table, giving voice to science. I heard from more activists like scientists, and I heard from more scientists like activists this week than I have at any of these conferences before, and it was awesome.
Well, I think about the first plenary, which had Phil, Tony Fauci, Secretary Clinton. I mean, it brought all the pieces together, so it set the right tone.
You've always talked about that a lot, trying to run a marriage the two, and that's kind of hard to do, isn't it?
It is hard to do because it takes lots of work, lots of work, and it's not cheap. It's a big proposition, and you have to stay at it day in and day out. You can't, like as Jen said, you have to be careful. No, it is an epidemic you can't turn away. So I think that one of the things that we did is we kind of brought up some of the energy, and people made a new commitment for the long haul, and we reminded people that this is hard work, and it's really hard work, and we got people to embrace that.
I'll ask you a very personal question. You've been living with HIV, what,
32 years.
2 years. When you look back from day one to now, I mean, through this conference, take us a little on that journey in terms of how we've progressed.
Well, I think that, when I was diagnosed with HIV, a long-term survivor was someone who lived 18 months. I was 24. I'm 56 now. And the fact that I'm alive today speaks to the success we've had so far. The fact that I used to write about, and my signature phrase is about the day when this epidemic will be over. And it was always in the context of, and it wasn't conscious, but now I think it was in the context of assuming that I wouldn't be there. And so the reason why I kept repeating that, because I didn't anticipate that I would be able to say it when it happened. Today, I think that I might very well be able to say that when we're talking about HIV in the past tense. That it is still a little difficult to wrap my brain around that, but it is an amazing feeling to think that someone who gets infected today, that if they go on treatment, again, those ifs, if we do what we're supposed to do, that they in fact can live to have a full life.
Wow. It's amazing. I have to say this. Phil is a person who kind of evangelized going to the black community, going to the press. It's like making everybody feel guilty. Make civil rights leaders go and saying, you better take a test. And I give you a whole lot of credit for that, you really do. But I want each of you, we're about to close up now, about to end, I want each of you to leave me with one lasting thought from this conference and how you're going to go back and try to implement what you've heard and seen.
I want to keep the energy. I'm exhausted right now, but I am re-energized, and that says a lot. And I think we have shown the number and breadth of people, communities from around the world, stakeholders that came here, that heard, that talked, that participated. It's really going to help us move forward.
Dejan?
Yeah, I absolutely agree with Jen. I think that there's a lot of opportunity to tap into the excitement, not just for the HIV community, but for the broader community. And so the one thing that I go back with is how much more engaged we want to make sure community is. And not just people living with HIV, but their whole families, so that they learn how to, that my family wished they had been at this conference just because we were feeding so much to them, and they don't live, breathe HIV every day. So I think that that's another message that we want to take home.
Yeah.
Well, the thing that I was most moved by, interesting enough, at this conference is that speaker after speaker after speaker from developing countries, came to the podium and they thanked the American people. They thanked the American people for what we've done for them. And that is a tremendous honor, and folks who don't do this work every day, they need to know that. They need to know that they are saving lives of people that they never will know, that they never will meet. And the last thing is that we can win this thing. We can win this thing. And for so long, we didn't know that. No, we didn't think that. And so much of our time was spent on deathbeds and burying our friends and caught in the morass of mourning. And now there's a new dawn. We can beat this thing, and it happens again if we do what we need to do.
And you're here to see it.
And we're here to see it.
Thank you so much for a great conversation.
Thank you, George.
And thank you for joining us. I'm George Curry.